Hello, can you guys hear me okay? Thank you guys all for coming. We're very excited to be here today to teach you guys a little bit about stroke. We'll kind of go through some of the PowerPoints and talk to you guys, but it's really to answer you guys' questions and help raise your stroke education and knowledge so that you guys are able to know more about stroke and how to recognize it and some of the things that we do to help patients that have had a stroke. So we're excited to be here. I am Gretchen Crabtree. I'm a nurse practitioner at Riverside. I used to work in the neurocritical care and still do there a little bit, but I am now a manager of nurse practitioners and physician's assistants there for our neuroscience line. And then I also work on mobile stroke, so the stroke truck that drives around the city. So if you guys have questions about that today, please don't hesitate to reach out to us. But I'll let my colleague introduce himself.
Gretchen, I don't know what neurocritical care is. What's that mean?
It's for the very sick patients that have brain injuries. So it's an intensive care unit specifically for patients that have brain and spinal injuries.
All right. Well, good afternoon. And we can't thank you enough for right after lunch or it's kind of nap time, right? For some of you, and we understand that. But thank you very, very much for spending your afternoon with us and talking about this very important topic about stroke. My name is Heath Good. I'm an educator for Ohio Health, but my full-time job, so with Ohio Health, it's just a part-time job for me. My full-time job is I'm a firefighter paramedic in the city of Hilliard for Norwich Township. So I've been to this facility on 911 calls many times, several times. Not many, but several, okay? So I'm very familiar with this facility. And again, Gretchen and I want to thank you. We want to answer any question that you have for the next however long we're here. Yes, we're going to talk about stroke. But if there's a burning question that you have that is maybe medical related or maybe even fire department related, I'll do my best to answer that question, okay? We apologize. We didn't realize that we would have 80-something people in the room, and we brought just a...
Your mask off.
Mask off?
Yes.
Yes, mask off. Now you can hear me a little bit better. I don't sound muffled, so I apologize. We will do our best to bring some more books back tomorrow, and hopefully we'll come back and do this same lecture again, and we'll make sure that we bring a whole box of brains, so not just a little bag of brains. So we'll do our best to do that. So, anything? So first off, I want you to raise your hand. Who in this room knows someone that's suffered a stroke? Pretty much everyone. Would you agree? You know, stroke is one of those things that's affecting so many people. And if you would ask maybe someone that's my age or even someone that's school age, they would say that stroke only affects old people. Who believes that's true? Very good. Very good. It's not just old people. It's not young people and middle-aged people. It's affecting everyone. And if you look at this, about 800,000 people per year. That's a lot of people that are suffering strokes. It says that every 40 seconds, someone in the United States has a stroke. Every 40 seconds. So what's that say? It says strokes affecting a lot of people in an alarming rate, right? And we could talk about, we'll get through some of these slides as to maybe why it's happening, right? It's the leading cause of death. So one of a sad thing, and one of the things that Gretchen's colleagues in the hospital and my colleagues in the pre-hospital setting of recognizing that people are having strokes and getting them to the correct facilities is so, so important. Because the leading cause of death, you don't have to die because you had a stroke. Now, 10 years ago, maybe 15 years ago, 20 years ago, 30 years ago, people died from strokes. Because, and Gretchen can talk more about this, is it's so difficult for us to understand, but just a few short years ago, 15, right, Gretchen-ish? 15 years ago, there was no treatment for stroke. So if you think about this, think about a family member or a loved one that you had or a neighbor that suffered a stroke and they couldn't do what they loved to do because they had a stroke. And the reason why that is, in the United States, there was no treatment for stroke 15 years ago, not too long ago, right? Fast forward to where we are today, we know that there absolutely is treatment for stroke, that we're doing it at very high levels, and we should be very proud of where we live, because some of the best facilities in the country are right here in Columbus that take care of strokes. Riverside, Ohio Health, Riverside being one of those, okay? So leading cause of long-term disability, you know that. There's probably people that live here that are suffering long-term disability because of a stroke. They maybe can't walk anymore, or they can't use their right arm or their left arm, or maybe they have trouble with their speech or trouble with their vision. That disability is what we're trying to change. We want to recognize and treat stroke at a very high level so you don't have to deal with a disability. That's what we're trying to do. Lots of money is involved in stroke. You see that number there, $75 billion a year. There's lots of money, whether it be research, treatment, all that stuff that's surrounding this thing called stroke. And we're doing it at a high level. Go ahead, Gretchen. You want to talk about that?
So really the reason we're here today is to talk to you guys about what is a stroke. So if you hear someone's had a stroke, what does that actually mean? And you can see from some of the pictures on the side, so it's a sudden brain dysfunction due to a blood vessel problem. So if you think about it about the plumbing in a house, and you have a block in one of the plumbings because your arteries are what's carrying that blood flow up to your brain, okay? And so if there's a blockage or a problem in one of those arteries or that plumbing that's feeding that blood supply to your brain, then that area can't get blood supply anymore and it starts to die. That area of the brain is going to start to die, okay? And that's when we see those deficits. So it's a sudden problem to a certain area of the brain. Believe it or not, there's two types of strokes that we talk about. The first one is an ischemic stroke. And what that means is it's a blood clot that travels either up to the brain from a heart or somewhere else, or it's a blood clot that gets stuck in the brain from plaque or things like that. And that's what's causing the problem. Okay, so first is ischemic stroke, and that's a problem with the flow into the brain through the plumbing in your brain or your arteries. We also have hemorrhagic strokes, and those are those bleeding strokes, okay? And those happen from multiple reasons, but that blood vessel ruptures within the brain, causing bleeding into the tissue of the brain that causes the deficits. So one's from a lack of blood flow in the ischemic stroke, and the other one is because of bleeding and damage to that area, okay? There's, whether it's an ischemic or a hemorrhagic, we differentiate between the two because it really depends on how we're going to treat you once you get to the hospital and the options that you have for treatment. With hemorrhagic strokes, that hypertension, high blood pressure is a lot of times what happens because the wall of that artery over time weakens from that high blood pressure and it ruptures. You can also have aneurysms that rupture as well. So several different ways that you can have bleeding into the brain, okay? But you can kind of see on the blood vessel in that top corner over there, I don't know if my pointer will work. It's okay. In the top picture, plaque or a blood clot. Those are the two things that cause that diminished flow. Whereas with a hemorrhagic stroke, over time, that weakened artery kind of outpouches a little bit, and then you have it burst, and that's what causes the bleeding. The other thing that sometimes you'll hear about is patients that say that they had mini strokes or TIAs. And these TIAs, for anyone that maybe suffers from angina from their heart or have had heart attacks and you get that chest pain and angina, it's the same thing for the brain. So it's a transient ischemic attack. That's what TIA stands for. So we want to make sure that you are getting evaluated because it's kind of a warning sign. It's saying that, you have something that's going to potentially cause a stroke and a big stroke later on. So you want to get evaluated what caused it. Most of the time, these are from thromboembolisms. Again, those blood clots or plaques that form in the brain or travel to the brain, but your body breaks up that clot before it can cause so much damage that it's permanent, or causes so much, it breaks it up before, those symptoms persist. Okay, and those warnings, and so it's a warning sign. So we really want you to go to the emergency department. If you've had facial droop or trouble speaking or weakness on one side of your body or some of the symptoms that we'll talk about here in a little bit, we really want you to get evaluated because we don't want you to go on, even if those symptoms subside, we want you to get evaluated so that you don't go on to have a stroke within 2 days. About 10% of people will, 15% in 3 months, and 25% will have a recurrent event. Okay? So really it's your body saying a warning sign before you have a bigger stroke. Okay? And we really want to focus on what caused this. We'd want to do a stroke workup at the hospital and have some tests done to see what caused you to have these symptoms so that you don't have ones that could leave you in that permanent state of disability later on. So when we talk about stroke, there's some things that we can control, risk factors, and there's some things that we can't. Unfortunately, the older you are, the more likely you are to have a stroke. That's one thing that we can't change, even though we would all like to, is our age. So you just live long enough, you're at a higher incidence and at higher risk of having a stroke. Men are more likely to have strokes more than women, but ironically, women have more strokes. Even though men are more likely to, and they're at higher risk, more women have them. Does anyone know why or have an idea? Live longer, yes. We live longer to be able to have more years to potentially have that stroke. Race and ethnicity, there's certain races that just are at higher incidence of hypertension or that high blood pressure. And so those factor into having a stroke. And then family history. Unfortunately, we'd all love to be able to pick and choose who our family members are, but unfortunately we can't choose our genetics. So family history of an early heart attack or MI or early stroke predisposes us or makes us at higher risk. So some of the things that we can control, hypertension, which is that high blood pressure. So making sure even if you have it, checking your blood pressure frequently, making sure that you're taking your medications appropriately, and following up with your doctor on all these things. Diabetes is another one, so making sure that you keep your blood sugar levels lower, your hemoglobin A1C within the range. Dyslipidemia, so what the heck does that mean? Cholesterol problems. So if you have higher cholesterol, that predisposes you to having a stroke. People that are overweight, cigarette smoking can also cause it. If you've had a prior stroke or TIA, you're at a higher risk of having another one if you don't kind of figure out what the cause is. Heart disease is another carotid disease. So those arteries that are in your neck are your carotid arteries. So if you have blockage in your carotid arteries, that can predispose you or make you more likely to have a stroke. Hypercoagulable states. So this is more for our younger patients because they, or even now, we see a lot of strokes more with patients that have had COVID and have making their blood more susceptible to clotting and making it more likely that they'll have blood clots. So patients that maybe they have genetic factors with like factor V Leiden or clotting disorders within their family are more likely to potentially have strokes. So we know that with COVID, it can cause increase in your clotting factors and it can lead to blood clots. And then cocaine and excessive alcohol, we see that a lot with our younger populations too, of those patients having strokes.
Yeah, I wanted to go back to the blood pressure issue and the TIA issue. So that always, people worry about that because your physicians are constantly talking to you about your blood pressure, right? And one of the things I always say is if someone would ask you what is normal blood pressure, what would most of us say? Yeah, 120/80, because for many years, your physician said, that's normal blood pressure. And if you go to the physician today with 120/80 blood pressure, they're probably going to talk to you about hypertension, high blood pressure. And they may even decide to put you on a blood pressure medicine, right? So that 120/80 blood pressure that many of us have thought for years and years and years and years is normal blood pressure is on that verge of high blood pressure. So we want to talk to your physician about managing your blood pressure because of this risk of stroke. The other thing that Gretchen was talking about was TIA, and I wanted to put a visual into your head how this works. And I had one my last day at work. A family was, they had their whole family over, and Grandma had a TIA. Now, what does this look like? Grandma couldn't pick up her tea that she was drinking that evening. And she was sitting at the dinner table with everyone, and they were playing a board game. And she had her tea, and she couldn't pick up her tea. And so they got nervous. They felt like Grandma was slurring her words a little bit. Grandma couldn't use her arm. They called 911. We showed up, fire department showed up, and Grandma was fine. And the family was like, what happened? What happened? Grandma could not pick up her tea. She couldn't use her right arm. And then all of a sudden, it's all fine. And we don't know what happened. So that was a TIA. That is a TIA. The symptoms kind of resolved over a short period of time. Sometimes it could take hours, an hour, even 2 hours, can be a little bit longer. But it is important that, just like Gretchen said, that you go get evaluated. So if the fire department's talking to you about you really should go to the hospital to get a further assessment done, that's the reason why. Because the likelihood of you having a stroke, just like Gretchen talked about right here, 10%, 15%, 25%, it's kind of highly likely that that you may have a stroke moving on. So let's talk about, if someone is having signs of a stroke, we like to use this thing called Be Fast. And it's just a simple mnemonic to kind of help you remember something about stroke. So Be Fast is what you're thinking about. And the first one is B, loss of balance or coordination. Some of you may have that on a normal basis every single day, right? We're not talking about what's normal and what's abnormal, right? So if you're a little bit off balance, you use a walker, that's normal, that's general, it happens every single day. It's that new onset of loss of coordination. Maybe you can't pick your coffee cup up in the morning, or you're having trouble holding your pencil, or men, you're trying to shave your face in the morning and you're all over the place. Lack of coordination, all right? That's what we're talking about. Balance and coordination. So that's your B, all right? E is trouble seeing out of one or both of your eyes. So maybe you have blurry vision all of a sudden. Maybe you wear glasses or you don't wear glasses, but you notice that something's not right. Blurry vision, double vision, something's just not right with your eyes, all right? So that's what E is. Facial weakness is F. Maybe you notice you're at dinner and you notice your friend or your neighbor or whoever you're with that, stuff's falling out of their face. Food. Maybe you noticed some facial droop, right? Now, how would you recognize if someone was having a facial droop? What would you tell them to do? Smile, right? And even a little bit further, what I always do when I'm, working is I say, show me your teeth, right? Because if I ask someone to smile on command, like if I come up and I say, ma'am, can you smile? Some people give you a half-hearted smile and you're like, come on, smile for me, right? So I always say, show me your teeth. I want to see as much as you can to kind of recognize whether you have a facial droop or not. A, arm weakness, right? One of the things we do here is, we say, close your eyes and put your hands right up in front of you. Like this. All right? We always say, what do we say, Gretchen? Like you're holding a pizza in front of you, right? Close your eyes, put your hands right out in front, just like this, and like you're holding up a pizza. And if you start to see a little bit of a droop, that lets you know that not 100% you're having a stroke, but you definitely want to call 911, all right? So arm weakness there. Speech difficulty. What does that look like? It looks like slurred speech. Maybe you're having difficulty saying and formulating words. Maybe you're talking kind of this out of your head, just like almost like drunk, right? And maybe that person does not drink, does not have any issues, is pretty tip-top, and all of a sudden they are talking just off the wall, and you're thinking, what in the world is going on? Could be a stroke. Did I say that right? All right. So slurred speech, maybe just difficult, forming the words to get out, and then just kind of off the wall, just making a bunch of almost to the point where you get really concerned. You're like, what's going on with John? John's normally pretty tip-top, and all of a sudden he's just talking out of his mind, right? Could be a stroke, all right? T, time to call 911. I always say, and I can say this because I do 911 work, is call 911 every single time. Do not ever, 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 never be afraid to call 911, okay? Everyone understand that? Don't ever be afraid to call 911. Don't ever sit in your home and say, I don't know. I don't want to bother them. I'm not real sure. Should I not? Always, always, always call 911. If we show up and you say, I'm sorry, I wasn't really sure. I just needed some reassurance. That's what we are there to do. Just because we show up doesn't mean we need to kidnap you and take you to the hospital. We are not in the game to kidnap people, right? We get in big trouble if that happens. Is that clear? I hear that so often, and it breaks my heart to hear someone say, well, I didn't want to bother you, and I didn't know if I should. Call 100%, call every time. We will help you. We will, if we need to take you to the hospital, that's what we'll do. But if it's just a quick reassurance or a quick, whatever it is, we will help. That's what we're here to do, okay? So that's B fast. So balance is the B, E is the eyes, F is facial, A is arm, S is speech, and T is time. That's the big thing there. Did I miss anything?
I think the only other thing to emphasize is if you recognize that you feel like your speech is a little bit slurred or you're having weakness on one side, the worst thing that you could do is go take a nap. 99% of the time, you're going to wake up and those symptoms are going to be worse. Okay? So we want to make sure that you guys, if you're having some of these symptoms, if you're having vision issues that are out of the normal for you, if you're having weakness on one side that's not your usual, please call 911. Don't go take a nap and think, oh, I'll feel better once I wake up. I'm just tired. Okay, call 911 so that we can treat you because we have certain windows of time that we're able to treat these strokes in. And we want to make sure that we're able to give you that treatment so that you don't have that disability long term. So this is a very busy slide and a lot of information on it, but I just wanted to be able to show you guys that there's different arteries within the brain that feed that blood supply to different areas of the brain. And depending on which artery has that blockage in it or the blood vessel problem depends on what your symptoms will be. So not every stroke has the same symptoms. So depending on where, it could be a very small blood vessel that has that clot in it, and you're going to have very small symptoms. Okay? You could just have a little bit, you can't write your name today. You just all of a sudden you have trouble writing, and that could be your weakness. Or it could be a big artery and one of our bigger blood vessels in the brain, and maybe you can't move your left side at all. Okay, you have slurred speech, you have that facial droop, and you have a lot of those symptoms and those signs that we just talked about. So it depends on where in the brain that blood vessel is having the problem, tells you what kind of symptoms you're going to have.
Some people would tell you that big strokes equal big deficits and small strokes equal small deficits. And some educators and some professionals would say that to you. I don't like that because even if I have a small stroke, which some people may say you should only have small deficits. Even if I have a small stroke, I may not be able to do the things that I want to do as a 45-year-old male that's still working as a firefighter. So if I have a small stroke, I may not be able to do my job, my career that I want to do. Same way, maybe you're a concert pianist. Right? Or maybe that's your hobby and that's just what puts you in a happy place. And if you have a stroke and you have a coordination issue that you cannot play the piano anymore, what does that do for your life? That's a big deficit, right? Even though in textbook and in the stroke world, that is a small deficit or a small stroke. Does that make sense? So be real cautious about if someone says, well, it's just a small stroke. No big deal. No big deal, right? I mean, strokes affect people differently, whether it's a big stroke, small stroke, it doesn't matter. Stroke is a big thing. Gretchen did a great job of explaining that slide. It is a busy slide, and the strokes affect different parts of the brain.
So treatment. How do we treat these strokes? We have multiple avenues to be able to treat these strokes. Luckily, over the last 15 years, we've been able to do a lot of research, not only in the United States, but throughout the world, to look at what is better and how do we treat strokes. 25, 30 years ago, it was all of these heart hospitals popping up, McConnell and Ross, and a lot of these heart hospitals because everyone was treating heart attacks. And those stroke patients just went to triage or went to the corner of the ED and then went on to a facility, and we weren't able to do much for them. Now, after having all of that research that we've done for heart attacks, now we realize, well, we can use some of that same treatment for the brain because they're both blood vessel problems that people are having. So the first treatment that we can use is called Altiplace, or TPA. And it's really a clot-busting drug. So it goes in and it binds or connects with the blood clot and helps break it up. That's really what that medication does. We give it through an IV or a line in your arm, and it's a drip that goes over 60 minutes. And so that's how we're able to treat those blood clots, is we help break it up. So the first thing that we need to do when you get to the hospital is get an image of your brain, a CAT scan, to make sure, is this a bleeding stroke or those hemorrhagic strokes, or is it from a blood clot? And that's how we know whether it's safe to give this clot-busting medication. Because if you've had a bleeding stroke, because we can't tell just by your exam, just by assessing you and saying, doing your arms or eyes or things like that, we can't tell whether it's a bleeding stroke or whether it's from a blood clot. So we need to take that picture. So once we've gotten that picture, then we can look at some of the treatment options. The sooner we can give these medications, the better. That's why we want you guys calling 911 as soon as you recognize those symptoms. The longer you have symptoms, the more damage it is doing to that area of the brain, okay? So we can only administer if there's no bleeding, and it's about a 3 to 4.5 hour window. We've done a lot to look at imaging and some of those scans that we're doing at the hospital to extend that window even further. But that's still right now, for most patients, that 3 to 4.5 hour window is where we like to give the Altiplace or TPA. Tenecteplase is a newer drug that we're using, and we've used it for heart attacks for a long time, but now we're using it for brains as well, for patients that have had strokes. It's for those strokes that have large deficits, those large arteries in the brain that have a clot in them. And so that's when those come most into play, and using it for those instances.
So I'm going to certify you guys in stroke treatment real quick. So Gretchen talked about large vessel occlusion, that last bullet point there, and she keeps talking about large strokes. Now, what does that look like? Now, any physicians in the room? Any nurses in the room? Okay, thank you for your service. All right, so we got one nurse. The rest of you are just whatever you did, and thank you for that. So what does this look like? Every single one of you in here knows what a large stroke looks like, and you've seen it before. You walk in and the person's slumped in their chair, their face is drooling, drool's coming out, they got really facial droop, they can't move their arm, maybe they can't move their leg. That is what Gretchen's talking about as a big, large vessel stroke. Does that make sense? Just to kind of give you a visual picture. You can have, I tell our paramedics all the time, you can have no medical training in the world at all and be able to, or at least you should be able to pick up on a large stroke, right? That's big deficit, like can't move the arm, they're slouching, they're drooling, big deficits equals those large strokes. Go ahead.
The other treatment that we can do is what we call a thrombectomy. Has anyone had a heart cath where they go up into your groin and into your heart to assess your vessels? Yeah, so that's the same thing that they do, but instead of going to the heart, they go up into the brain, and they're able to pull those blood clots out. So you can see in this picture over here, this is where the clot is. And if you can't tell, there's always a nice arrow for you, right? So this is where the clot is, right in here, in this artery. So they were able to pull all of these clots out. And now you can see how much all that dark space over here and all those squiggly lines, those are all blood vessels that now have blood flow back to them because they were able to pull those clots out. Because it's hard for the catheters to get to some of the smaller arteries in the brain, these is a lot of times only for our large vessel occlusions or our large strokes. But within, 12 to 24 hours, they're still able to do these brain caths on patients that are having a stroke for these large deficit strokes that we're seeing.
This right here is something to get excited about. I mean, this, like we said, a few short years ago, they couldn't do this. And the fact that we have 3 facilities in Columbus that do this is amazing, amazing. And, certain places of the country, you have to drive hours to find a place that does this. And we have 3 of them right here in Columbus. So Riverside, OSU, Maine Hospital, and Mount Carmel on the east side does this. So, when we're out teaching, it's definitely something to get excited about. I mean, it's truly amazing that you can put a catheter into. There we go. He got it. That's all right. It's truly amazing that you can put a catheter into someone's artery and go all the way up into their brain and pull out a clot, this picture here, and have no deficits. Absolutely amazing.
So one of the other things that we're lucky in the Columbus area to have is what we call the mobile stroke unit. Here in Columbus, we were the 15th in the country to be able to have this, and the 3rd within the Ohio region. So because we love to say the idea, time is brain, the faster you can get treatment, the more brain cells you're saving. So that's our goal. We want you guys to be able to save brain cells and get that treatment. So this is pre-hospital treatment. This is bringing the hospital to the patient. So within the mobile stroke, we have a CT scanner in the back of it. So you can see the kind of the donut in the back. That's a CT scanner that we can bring you out of the facility or bring you out of your house into your driveway or into the parking lot, and we can do a scan of your brain right there, right at your house or wherever you live. Based on that scan and the exam and our assessment of you, we talk to our neurologist who's able to camera in. So there's a camera in there, and they can do a virtual visit with you and say, yes, I'm seeing the same things that you're seeing. Let's go ahead and give treatment. So we can give that Altiplace and that Tenectaplace prior to you even getting to the hospital. We do blood work and we do the CT scan to say, yes, it is safe enough to give this treatment based on everything that we know, and we want to get you faster treatment. Okay? And we have seen very good results so far. We've been in service for 2 years, almost 2 years. And we've seen very good outcomes for patients that otherwise may have not had that good of an outcome. So it has 4 staff members on the truck each day. We have an advanced practice provider, or an APP, so a physician assistant or nurse practitioner. We have a CT tech to help run the scanner for us, and then we have 2 paramedics that help us with medications and starting IVs and getting our lab work. And I always joke around that they're also my chauffeur for the day as well. So, and then we also have our telehealth doc. So the same physician that's seeing patients at the hospital on the camera is also able to camera in to the back of the mobile stroke and talk to the patient.
Gretchen is very humble about the mobile stroke unit, but the APP, the nurse practitioner, that's Gretchen, and she rides this truck. She's one of the first ones to do it in Columbus, and it's another reason to get excited that you live in Columbus, Ohio. That we have this available to us. Now, I will say that not every time someone has a stroke at Friendship Village will this truck show up, because there's only one of them. And we wish there was 4 of them or 5 of them. But obviously, this comes with a large price tag. It has a CT scanner in the back of it. That alone is a large price tag. It is a collaborative effort. It's very hard to see these logos, but Ohio Health's logo, Columbus Fire's logo, Mount Carmel, and Ohio State. So one of the questions that always comes up says, well, I go to Ohio State. Can you take me in this truck to Ohio State? Yes, they'll go to Ohio State if that's what you want to do. And then the other, like I was saying, not always will it show up here. The best situation may be to have the fire department load you up and get you to the hospital. Maybe this truck's on the east side. So sometimes it just doesn't make sense to kind of sit and wait. Sometimes it does. This truck's in constant communication with our dispatchers and knowing where they need to go and their destination, hospital. What's the fastest way to do that? And like Gretchen said, this is the hospital. So for example, if this truck shows up at Friendship Village and it's just sitting in the parking lot and everyone's like, why are they sitting there? They should be going to the hospital. This is the hospital. It has everything in it that the hospital has. It has the advanced practice person in it. It has the CT in it. It has all the drugs in it. It has the physician is talking to the crew that's in the back. Everything's being done right there. So that alone is a little bit different. Even for paramedics, it's difficult for them to understand, like, what do you mean you were sitting? Because as a paramedic, we were taught, get the patient, go to the hospital. Get the patient, go to the hospital as fast as you can do it. This is the hospital. So sometimes it makes sense to just kind of hold the brakes a little bit and let's start treating right, and then we can get it to the hospital. Does that make sense? Anything else? I think that was all the slides, wasn't it? Yeah. That's really as far as the slides that we have, we are happy to answer any questions. I know this is a large group, but if there's anything that we could answer, we're happy to do. Yes, sir.
Show you how naive I am. What's the difference? How can you tell the difference?
Okay. Yeah, that sounds good.
What is the difference, or how can you tell the difference between someone having a stroke versus a heart attack?
Yeah, good question. How do you tell the difference between someone that's having a stroke and someone that's having a heart attack? So a stroke, a lot of the things that we look for is this FAST exam, or the BFAST exam, right? So balance, eyes, arm weakness, speech, that type of thing. That's what we're looking for in a stroke. In a heart attack, we have the heart monitor, the EKGs, right? So the paramedics will put all these patches on you, and they'll look at your heart monitor and your heart rhythm to see whether you're having a heart attack. And then the symptoms that you may have with a heart attack are chest pain, or maybe just a dull, achy pain in the belly or the epigastric area. So that's more indicative of a heart attack. And then that's confirmed with an EKG. And another very, very cool thing that many people don't know about is all the paramedics in Ohio, if you will, have the ability, if I come to your house and I hook you up with an EKG machine, I hit transmit on my machine in your house that goes directly to the ER. The ER looks at it and they says, yep, it's a heart attack. That same EKG that I'm doing in your house goes directly to the cardiologist's phone. He pulls it up, he looks at it and says, yep, the medic's on their way, they're bringing this person, and that's for sure a heart attack. That is crazy technology, right? That a cardiologist could be sitting, let's face it, sometimes on a golf course, right? Or at his house, or even in the hospital, right? And he knows that you're coming with a heart attack. Does that make sense? Crazy technology. So when we get on our kids about technology sometimes, technology's pretty cool, right? Technology's pretty cool. That mobile stroke truck, all technology, all technology. Yes, sir.
I'd like to extend that question to seizures, the difference between seizures and stroke.
Yeah. Go ahead. This is a good one in stroke. Go ahead.
It's difficult. I will say that, even for providers to tell the difference between a seizure and a stroke. So we look at what the patient looked like when the symptoms started. Did they stare off and would they have like a blank gaze? When the symptoms started, did they have the limbs shaking? Were they just not as interactive with you for a period of time, a minute or two, even though you were talking to them? Were they just kind of staring off? So we think about what happened when those symptoms came on. Because even after a seizure, you can have weakness of one side of your body. And it can mimic or look like a stroke. So regardless of whether it truly was a seizure or a stroke, we want to make sure that patient comes to the hospital, because we can do some of that imaging to say, yes, it was a stroke, or no, it was a seizure, and we obviously treat them very differently. But it is very difficult, and we do have a lot of patients that come to the hospital as a pre-hospital stroke alert that we then get imaging and realize, no, it wasn't a stroke, it was a seizure. So seeing what that patient was doing or what that person was doing when those symptoms started, and sometimes we don't know because no one witnessed it. We found them with weakness on one side. If they have weakness on one side, sometimes there's other symptoms with it, with the facial droop, which you don't see in seizures. So there's some other things, but anytime someone has that weakness, please call, and then we can kind of tease it out at the hospital, whether it was a seizure or a stroke. Sometimes it's just off a history. The patient has a history of seizures, and so we know that this may have been another seizure despite them being on medications.
Yes, ma'am.
I had a question about the TIA slide where there were 25, you had 25%. Oh, okay, all right. 25% have a recurrent, and event was in parentheses, or I'm wondering, what were those events, like a repeat of the TIA or something else? And then what happened to the other 50% that you don't mention?
So yes, the 25% that had the event is another episode of those symptoms that resolve prior to getting to the hospital, or after an hour or so. The other 50%, sometimes people don't go on to have strokes, and it was just a one-time occurrence. But it is a higher likelihood. If I'm rolling the dice and I have 50% that I may have another stroke, or 50% that I'm not, I would rather just go ahead and get evaluated. I'm not playing the 50-50 game for sure. So.
Yes, ma'am. Yep. Ava's coming. She's got a mic.
I'm coming in.
I'm hard of hearing myself, so.
Recently, I had an emergency visit to the hospital. They came and got me and took me, and I have AFib. And after I got there, they did a scan. And they didn't tell me why, but they did a scan. Did they do that because after hearing what you guys are saying, did they do that to see whether I was having a stroke?
So sometimes people have strokes that they don't even realize because it affects such a small portion of the brain. So they may have wanted to see if at some point in time with the AFib that maybe very, very small clots from your heart traveled up into your brain, and maybe you had a stroke and didn't realize it. So they just want to, see what happened, and that can kind of help determine which treatment would be best for you based on your risk factors and your lifestyle and things like that.
Well, I have what's called the Watchman.
Yeah.
I have what's called the Watchman, which is supposed to keep me from having blood clot,
Yeah.
to gather. Okay.
Yeah, your little net that catches those clots before they go anywhere. Yeah.
Ava, I have a question for you. Do you have a File Life program here?
We do, yes.
Okay. So I'm going to talk about that just for a brief second. We'll come back to you. If you're not familiar with a file of life or vial of life, places call it different things. All it is a piece of paper with all of your pertinent medical information on it. So your name, your date of birth, your address, maybe an emergency contact, your history, like if you have heart, diabetic, stroke, whatever, all your medications, what you're allergic to. If you do not have that now, you can, Ava or someone can help you do that, or you can get on your own computer on Word, type all that out, print it, get a couple copies of it, and keep them somewhere in your apartment. So when I show up, 911 shows up, and they start asking all those questions. And sometimes it's an emergency, and it's kind of hectic, and people are a little bit worked up. You can just say, here you go. Here's all my information. And you don't have to worry about it. It is so helpful when we show up. Because many times people are in a panic, people don't remember, they don't know, and we're wasting valuable time just trying to get that information. So it is so important if you can do that. So, and if you need help, Ava, or we can come back and talk about that. We'll do them here if you want to do them. So, yes, sir. Ma'am, sorry.
Nan, I'm going to give you the mic so everyone can hear.
I just wanted to ask, do they still tell people to put that information on your kitchen cabinet door?
Yes, we do. So we in the past had an emergency manila envelope that we had you put in the cabinet above your sink. So some of you have that. We also started collecting it campus-wide so that we have it electronically, and it is in our medical record system called Point-Click Care that our security team has access to. So in the event that you are going out to 911, security is able to print that off as well. But I do encourage, one, getting it to us, but also having it physically there too.
It's so important. And you don't have to worry about security. I mean, all that information that you send to the staff here is 100% secure. We are not using it for any purposes other than getting your information to the hospital. That's it. So you don't have to worry about giving your information out. Yes, sir. I'm sorry.
I'm going to Cindy. I'll come back.
What happens if you have a pacemaker and for that reason cannot undergo the diagnostic procedure using magnetic resonance imaging? How much of a problem is that in a stroke?
Yeah.
So we're very fortunate with a lot of the technology that has increased our ability to see the images that we need from a CT scan. So there's a lot of patients that don't have pacemakers that are MRI compatible, and we are able to see what we need to based off the CAT scan alone.
I have a question just in regard to determining how to get the stroke unit to respond. So is it just you describe what your symptoms are, and the dispatcher tries to make a decision of if?
Yeah. So I was talking to Ava before. I believe this is Columbus's first run district. Do you know at all? I believe so. So the way it works is you call 911 and Columbus Fire comes here. They're the first ones that come here. And it's a stroke. This truck is dispatched at the same time. So you'll get the fire department to show up, a medic truck and a fire truck for a stroke. And then this truck is coming to here. If the team that shows up first says, oh, it's not a stroke, it's a seizure, right? They'll cancel this truck. And they're back in service and they can handle the next call. So if a stroke is dispatched from this facility, this truck's dispatched at the same time. So, but you're still getting a regular paramedic truck and a regular fire truck coming. They'll do the assessment, and then if they say, yeah, this is a stroke, they'll say, keep coming. Stroke 1 is what
Yeah, so based off the symptoms that you say, if you said, oh, I'm having, chest pain, they're not necessarily going to dispatch the stroke truck. But if you say, I'm having numbness or tingling, or I'm having weakness on one side, or, one of the other residents is having that's those keywords that you're saying, that's what will get the stroke truck coming here at the same time. So we have in where the stroke truck is housed over by the airport, just because of the close proximity to all of the highways, we can get places very quickly from the airport region. We have the same alarm system in our stroke building that the firehouses have. So when that engine and medic gets dispatched, the same alarms that's dispatching them dispatches us too. That's also to say that if, based on what you tell when you call 911 and the symptoms, if they're like, oh, I'm not sure, or maybe the symptoms aren't what triggers them to think stroke, but then the medics get on scene and they say, yeah, this person's having a stroke, they can then call us and add the stroke truck to the run. So there's been times where I know even personally, I've given someone that blood clot medication, that clot busting medication in a Tim Hortons parking lot, in a Lowe's parking lot, at a firehouse in their parking lot, where we've rendezvoused with the medics because we recognize that you are our only patient in the back of that truck, and you are our priority to make sure that you get the fastest treatment possible, and you have 4 dedicated people just to you. Whereas if you go to the ED, there's a lot of patients there, and even more so recently, right, with all of our hospitals being more and more higher volumes. So us maybe meeting them somewhere on their way to Riverside or OSU or Mount Carmel and meeting them in a parking lot or a firehouse may be what's best for you to get that treatment. So we really do a lot of communication with our medics and our engine teams and our EMS officers to make sure we decide what's best for the patient based on where the stroke truck is and the time it's going to take us to get to you.
Yes, ma'am.
I went through a spell where my heart stopped a couple times, and I ended up in ER, and they took me right up and put a pacemaker. Is it dangerous to do heart compressions on a person wearing a pacemaker? I mean, they think it's something else, not knowing it's a...
Yeah. Good question. So she said she has a pacemaker. Is it dangerous to do CPR on someone that has a pacemaker or defibrillator? And no, it is not. We see that very, very often. And, if you are to the point where your pacemaker defibrillator is not working, we have to do that for you, right? And it's not super common, but you're not the first one, right? So we're definitely going to do CPR for you. Yep. Yes, sir.
What's the definition and the cause of seizure?
I'll turn that to someone smarter than me. The definition of a seizure?
It's abnormal electrical activity in the brain. So you have neurons that have electrical impulses in them, and so it's it's increased electrical activity or abnormal. So that's what causes those seizures. Sometimes it's because of some patients have had a traumatic brain injury, or maybe they have, they've had a prior stroke, and so they have damage to an area of the brain that can cause seizures to occur there. But it's abnormal electrical activity, and that's why when they put, similar to all the patches that they put on someone to look at the electrical activity of the heart and determine how well it's pumping, and so if someone's having a heart attack, they can do the same thing and put electrodes on the brain to look at the electrical activity in the brain and determine if someone's having a seizure based on that.
I mean, your brain's, if you think of it in the most simplest form, your brain is the schematic of your, the electrical diagram of your washer or dryer or your furnace or your stove, whatever, same type of thing. So if you get a improper electrical movement can trigger seizures. A lot of people, maybe light triggers a seizure. So that's improper balance of that electrical pathway, if you will.
I was curious. You said that you dispatched the medics and a fire truck. If it's a medical emergency, what do we need the fire truck for?
Yeah. Ava, this is that question I told you that we get asked a lot, right? This is that question. That's a great question, and it gets asked all the time, whether we go to a young moms group or a senior living facility. I did not call for a fire truck. My house is not on fire. I don't need the fire department here. Most all firefighters are paramedics, okay? Most all fire trucks have all of the stuff that's needed medically to take care of you on that fire truck, right? So that means oxygen, that means a heart monitor, that means IV stuff, that means medication. All of that stuff is on the fire truck too. Now, why would we have that medical stuff on a fire truck? Because the fire truck may be the first or the closest emergency vehicle to your house or wherever they're dispatched, right? So that's why the fire department or the fire engine shows up first. They may just be the closest piece. They can start taking care of you medically. They're just waiting for the transport vehicle, the medic truck, to show up. And the other reason, if they both show up at the same time, it's manpower, basically, right? It's just extra hands to help, and that's why. So great question. It gets asked a lot. I didn't call for the fire. My house is not on fire. We are all paramedics. If we're not all paramedics, we're all EMTs. Some of them are EMTs, but all of that necessary medical equipment is on that fire truck too. Great thing. We're very fortunate, again, to have fire departments that do that. It's not like that in other areas of the country or even other areas of Ohio, if you will. So very fortunate for that. Yes, ma'am.
What is the thinking of aspirin, taking aspirin every day?
Yeah, so aspirin helps it doesn't completely thin your blood, but it helps so that platelets don't stick. So it's an antiplatelet. So it helps prevent those clots from forming. So it helps with your heart as well as your brain.
That's a good question. It gets asked quite a bit. Yeah.
Aspirin and Plavix, or clopidogrel, does not preclude you from getting the clot-busting medications. But if you are on a true blood thinner, then it does. So Eliquis, Xarelto, Coumadin, or warfarin, all of those preclude you. However, it does not preclude you or eliminate you from getting the thrombectomy or the brain cath. We're still able to do that no matter what kind of medication that you're on. But you are at too high of risk. Now, if it's been greater than 48 hours since you've taken your blood. Sometimes people come off blood thinners. They stop taking their Coumadin because they're getting ready to have an upcoming procedure. And within that time, unfortunately, some people do have strokes. And so even if you are on Coumadin, but your INR is low, below that level, we can still. But with the Xarelto or Eliquis or some of the newer agents, as long as you haven't taken it within the last 48 hours, we're able to give you those clot busting medications. But if you've taken it recently, then unfortunately we can't.
Do we want to, for the sake of people's time, since we're getting into 3 o'clock, wrap up? But if you still have questions, I'm sure Gretchen and Heath are okay to stay up there and take questions?
Sure. Sure.
Great. Thank you guys so much. We appreciate it.
Again, we're here. If you want to ask more questions, we'll be here. But again, thank you, thank you, thank you. It's a lot of people in a room and talking about a very important subject. And we know it's late in the afternoon and your time's valuable, but thanks for spending a little bit of your time with us. And we hope to come back. So if there's other information that we can provide for you, Gretchen and I are happy to. And if we're not the people, we'll get the people here to help you better understand. So thank you.